Hello and welcome to this webinar on the management of thoracic injury, which is brought to you today by ESTES, the European Society for Trauma and Emergency Surgery. We want to make this as interactive as possible. We will have a case presentation with a lot of interactive polls. There's no right or wrong answer in those polls, and every poll is anonymous, so please feel free to answer them. It'd be great to know what you think. Also, please ask any questions as we go along through the Q&A button, which you'll probably find at the bottom of your screen. We will try to answer them as we go through the webinar. Tonight, we have two presenters who are experts in their field. Raul Coimbra from Riverside University Medical Center in California, who'll be talking about thoracic trauma, and Pietro Bisagni from Lodi in Italy to talk about his experience of VATS in COVID. Joining them for panel discussions will be Jorge Pereira from Viseu in Portugal, Nikhil Misra from Liverpool in the UK, and Peep Talving from Tallinn in Estonia. My co-host, Hayato Kurihara from Milan, is going to present the first case. I'm going to hand over to Hayato to present the case. Hayato.
Okay, you see the screen, right? Okay, it's going to be a quite short case, but very simple and very common case regarding a blunt thoracic injury that we have seen a few years ago. That the case was prepared by Martina Cellin from my hospital. This is a male, an 80-year-old male, quite frail. He, on November 23, 2016 at 10 p.m., he arrived to the emergency department. His past medical history was a chronic renal failure, ischemic heart disease, and he had a pacemaker, hypothyroidism, and he was under medication with beta blockers and warfarin. So he was under anticoagulation therapy. Regarding the mechanism of the injury, it was a simple fall injury. He had a head trauma, dorsal, and right chest trauma. His vitals were normal. Glasgow Coma scale was 15. As a treatment, he had just a simple C-spine and C-collar, and a spine bore. During the primary survey, A was normal, B was quite normal. He had normal breath sounds. Oxygen saturation was 98%, respiratory rate 15. Blood pressure 110 over 40, 60 about 60 heart rate. Glasgow Coma scale was normal, and the E was normal. Regarding the labs, he had an INR of 1.7, hemoglobin was 11.8, and lactates were normal. At the EFAST, he had some right pneumothorax, and the pelvis X-ray was negative. And between the primary and secondary evaluation, we had a chest X-ray, pelvis was normal, and this is the chest X-ray that could reveal a simple right pneumothorax and some displaced fracture from 5 to 8 right ribs. So the patient was very stable, and I'm asking to all the participants and the physiology was normal. So what would you do? Had a drain directly the right chest or go to CT scan? Please reply to the poll. As Dr. Tilsed said, there is all the polls are anonymous, so please feel free to answer.
There is also no right answer and no wrong answer in any of the polls. Some of them are just more right than others. And we'll stop the poll there. And as you can see, the audience agrees that there is no right answer for this question, as it's split almost 50-50 between putting in the right chest drain and going to CT.
Great. And actually, what we decided to do was to go directly to CT scan, since the patient seemed to be with a very normal physiology. And so we could detect the pneumothorax and the hemothorax. And then actually, what would you do now? Drain the right chest or wait and see, since the patient was really very stable? We have a simple second poll. I think in this case, it's quite common in every emergency department every day, all over the world.
And as you can see, most people would drain the right chest, and about a quarter would wait and see what happened.
Right. So if you drain the chest, how would you, for those people who replied that wanted to drain the chest, how would you drain the chest? With a standard intercostal drain, ultrasound guided, CT guided? Again, patient was very stable. We could have time to take a decision.
Just a short comment, Hayato. A 80-year-old gentleman having a blood pressure of 110, is that stable?
Well, the lactates were normal. That was his blood pressure. Actually, he's usually had these vitals. That's why I specify the physiology seemed to be normal.
Yeah, I just the assumption that he should have a blood pressure of 160, 180. Perhaps maybe he was on a appropriate medication, but still, when an 80-year-old is having a 100 or 100, that's hypotension.
Yeah. Thank you for your comment, Pep. And anyway, the patient, I see from the polls that most of the people would put a standard intercostal drain. Some people US guided or CT guided. Okay. So, and we put just a standard intercostal drain, and we had some air bubbles coming out and 2 milliliters of blood, and he had some antibiotic prophylaxis. And for the course, the clinical course was quite good. Patient kept to be his hemodynamic stable, physiology was normal. So after 4 days, we had a chest X-ray that was okay. We had the chest drain removal. Hemoglobin was 10 and no signs of infection. And on day 5, actually, we discharged the patient at home and we organized an outpatient clinic follow-up. And I would like to have some comments from the panel after we finish the case. But unfortunately, 1 week after the trauma, that was actually 2 days after discharge, the patient came back to the emergency department. So we had a new emergency department access, and the patient was dyspnoic and septic. He was feverish, 38.6 Celsius. Blood pressure was 130, 70, heart rate 60. Still good oxygen saturation, but we had some signs of sepsis. He had the white blood cells counts of 25,000. CPR was markedly increased. So again, what would you do now? Right chest X-ray, right chest again, wait to see, or have a CT scan? And we have the 4th poll.
And as you can see, most people would go for a CT scan at this point.
Right. And actually, sorry, I think and this is the CT scan that we had. And we have the last poll. What would you do now? Many people would have already been positioned in a standard intercostal drain. But the question is, do you drain with some radiological assistance by ultrasound or CT When I say ultrasound, I said I imagine by ourselves as surgeon at bedside. Or does anybody would plan a thoracoscopy to drain and to evacuate, to clean the pleural cavity? This is the question.
I think most people have seen the program for this evening and decided that the answer is going to be VATS.
Okay, great. So 42% is going to have a thoracoscopy, and actually, we decided to put again an ultrasound guided drain and chest X-ray. Maybe Alan remember this case. But the clinical course, this is another point. We just used a standard intercostal drain, and then due to our organization, we hand over the patient to the medical ward where he had some antibiotics. He had a persistent mild drain output for several days. His coronal renal failure has been worsening a little bit, and that's why they have been keeping the patient in hospital. And actually, we could remove the drain 2 weeks after the second emergency department access. And the patient was then discharged on January the 6th. And that means that was about 1 month after the first access. And that was the course of the patient. So after that case, we sat around a table and we gave more emphasis to more focus on the pain management. We started to think an early physiotherapy involvement. We decided that we would have been keeping our patient with although frail, with a thoracic trauma in the surgical or trauma ward. And the question to ourselves that we have made that should have been more aggressive, maybe with an early VATS. And we decided to establish a clinical pathway for rib fracture. Okay.
Okay, thank you, Hayato, for that great presentation. A panel, what would anybody have done anything differently in this case?
I think in the first place, the first round, the patient came to hospital, was admitted. Was there any appropriate pain management, the physiotherapy added to avoid the second round? And what did you do with the warfarin?
So we suspended the warfarin, and we had we put the patient under heparin, low dose heparin. Unfortunately, the physiotherapy management was not really effective because in such so-called mild, not so severe patient, we try to teach the patient to have some physiotherapy on his own, and but this was one of the main points. Probably we have been lacking in this.
That most likely wouldn't avoid the retained hemo or the revisit. However, elderly ones, they are splinting, they are not doing good physio at home, so most likely that contributed that he came back, but the retained hemo or the hemothorax is the other issue.
Hayato, what was the nature of the drain output on his readmission? What did it look like? On
the readmission,
yeah.
Yes, it was like old blood.
Yeah.
But
okay.
Clearly, I think we did not make cultures of that drain.
Okay.
And that was, I think, we have been auditing that patient, and that was one of the critical points. It was going to be an empyema soon, you know. It was probably, it was already an empyema, probably.
Okay. And so, and do you think that was due to ongoing trickling of bleeding and a hematoma that built up and got infected?
Yes, yes, and you know, in the following days, it was always seromatic mainly,
Yeah.
but for a long time, and we have been waiting too much. Probably that's why I wanted to present this case, because we always want to present very nice, elegant case. I wanted to present a bad case, a bad management, because I think it's very common. And I don't know, at least in Italy, I don't know how many hospitals they have a pathway for these patients set in place.
And as I understood, you are a bit blaming yourself that the patient went to the medical ward. I would be worried too, to send the patient to the medical ward with a chest injury, particularly the elderly one. Was that a bad situation, or was that what was the reason?
Yeah, it's I'm working in a hospital where usually we have when we have a patient in the surgical ward, is a patient that is going to theater sooner or later. So some organizational issues within my hospital probably, you know, played a key role in the situation. But after that case, to tell you the truth, we had another case quite similar. After that case, we decided we don't care. We keep the patient in the surgical ward so we can follow up them daily. And we mainly we are not. It's very exceptional that we leave a patient to the internal medicine, because we can easily lose control of this patient. If we do not follow up them daily, we easily, you know, that patient that actually he was admitted to our nephrology unit because he was a patient that was going, 2 years later, this patient started peritoneal dialysis. That was 2 years later, you know. So I think at the time we thought it was a good idea to leave the patient to internal medicine management, but maybe, yeah, we blame a little bit ourselves. It was a very long and useless, we wasted many days of length of stay of beds for this patient.
Okay.
Oh, sorry, George.
You carry on, Nikhil.
Thank you. Hayato, the second drain was US guided. The first one was not. Was there something particular in the second time that made you use US guided, or you don't trust the anatomic guided?
No, actually, the reality is that the colleague that put the drain, he's very skilled in US in point of care ultrasound. So we just, you know, it's simple. You have the ultrasound there, and that was a second drain in a week. So he decided to leave the drain to use the ultrasound, just routine.
What was the size of that drain, the second one?
I think it was 26 French.
And what was the output? Was it good output?
Yes, it was a good output. Just after the drain, the patient really improved, and it was a good output, but we had a persistent leak for days, seromatic leak, you know, 150 cc, some blood and some seroma. but constantly for many days.
On that one CT image you showed after the drainage, I didn't think it looked too bad, but I haven't seen the entire chest CT. Were you happy with the CT scan after the drainage?
Yeah, actually, yes. The CT that the shot that I made was the worst part of the CT.
So Hayato, these are really, I mean, that was a really good demonstration of what is a very common case coming to any trauma hospital or any hospital. You know, we see this on a daily basis, basically, really common. And I think you've been a bit harsh. I mean, it's an excellent presentation, but you're being a bit harsh on the management. Saying that though, what do you think you would do differently? What lessons have you learned, particularly going forward, to make that better?
So definitely that where the last slide is be more aggressive with physiotherapeutic involvement, much more aggressive. That's the first point. Second, in the meanwhile, we focus more on pain management so that the patient can breathe better. One of the problems that we have is that sometimes the patient, they wait in the emergency department for a bed, sometimes for 48 hours. And during their stay in the emergency department, they just receive some paracetamol, that's it. So we decided that we have to start with a good pain management directly from the emergency department. And the other learning point was that I think as already said, we are going to keep this patient in a surgical ward, so we can follow up those patients daily. And we should be more aggressive and go for a VATS earlier, much earlier. And that I think it was one of the most critical point of the management of this patient. That's why I wanted to share with all the panelists and the attendees this case. And
certainly the epidural analgesia in elderly patient is a life-saving procedure. Nevertheless, he was on warfarin, so you need to reverse the warfarin, insert the analgesia or the catheter, and then start the low molecular heparin again. So it is an issue, but I think in elderly, it's been shown in studies most effective.
And actually, this is what we are going to do now. We have like a first line. We go with we are evaluating a protocol for pain management with drugs. And if within day one, the pain is not really controlled, then we go for epidural, without waiting too much.
We've discussed in a previous webinar that the problem with elderly patients is that very often they don't complain of any pain. You give them enough analgesia for the pain that they will admit to, but it's not enough analgesia for the symptoms that they have. And usually 2 or 3 days later, they have a pneumonia. Mauro, did you want to comment?
Yes, thank you. I only would like to come back to the issue of ultrasound-guided drainage. I think that is not only a skill, it's a kind of faith, probably, of the co-worker of Hayato. And I think the only meaning could be that you are sure where you put the drain. Moreover, because it was a second drain in a short delay. And secondly, you could stay more dependent than you can with the landmarks. And that could be one of the reasons for which they were able to drain enough. We can discuss about VATS or not earlier, but anyway, they were able probably to drain enough the collection because they put the drain really more dependent than you can do with anatomical landmarks.
And on those words of wisdom, I think we'll move on to the presentation from Raul Coimbra on the management of thoracic trauma. Raul.
So thank you very much for the invitation. I appreciate all the comments made by the panelists about this case, and hopefully I will cover most of them in my presentation. I'm just going to make one comment before, because I know it's not in my presentation about the case, is that it seems to me that this complication is common and expected in this case. And I think that the case could have been managed differently as it relates to its anticoagulation. This patient is elderly on warfarin with chronic renal disease. He has two predictors of failure of conventional treatment for hemothorax, chronic renal failure and the use of warfarin. His initial INR was 1.7. And so 70% above normal, and it was not reversed. It's not just that warfarin should be stopped. Warfarin should be stopped, and the INR should be reversed to an INR of 1.2. That's what most of the literature agrees on at this point, if the patient doesn't have a mechanical heart valve. So the complication seems to be the recurrent or retained hemothorax or recurrent hemothorax, depends how you see it, I think was a predictable complication. But let's go through the talk and try to cover most of the aspects of the case. So as it was said, this is common. About 20 million people per day have a chest injury. About a third require hospitalization. We know that blunt thoracic injury is responsible for 20 to 25% of all traumatic deaths, and chest trauma contributes to another 25% of the traumatic deaths if it's not the main cause. Obviously, the pathophysiology is related to impaired oxygenation, ventilation, eventually mismatch and changes in blood flow, bleeding, infection, and sepsis. And it occurs due to a multitude of injuries. And today we are going to cover primarily chest wall and lungs. And I'm not going to be talking about penetrating injuries or great vessel, which hopefully I'll be able to talk in a future webinar to you. So rib fractures are really the hallmark of blunt chest trauma. And if you see greater than 3 on X-ray, 3 or greater than 3, it's truly a marker of associated solid visceral injury, because it's a marker of a significant energy transfer to the body. It's not easy to break a rib, and if you see more than one broken, you need to think that this is there is something hiding there that you need to find. Particularly in the elderly, patients can have extensive fractures with minimal injury due to their osteopenia. And cases like one that Hayato present are again very common. Obviously, for the most part, most patients will do well with pain control and chest physical therapy. However, there are several nuances that must be observed. If you look at the impact of rib fractures on mortality, this is data from David Livingston in New Jersey, published several years ago in the Journal of Trauma, and you see that the percentage mortality goes up as the number of rib fractures goes up almost exponentially. There are other fractures that are important as well. Sternal fractures are usually secondary to a direct impact to the chest. 50 to 6% of those patients with a sternal fracture will have another significant injury. Most of the concern relies on the associated injuries, obviously, and particularly related to blunt myocardial injury. Sternoclavicular joint is something that we usually forget its importance. It's rare, but could be potentially fatal, leading to injuries to the major vessels, to the lung, to the airway, to the brachial plexus, etc. So it's important to have a thorough evaluation of your chest X-ray and your CT to rule out sternoclavicular joint fracture in patients with blunt chest injury. Clavicles are common, as you all know, but eventually they reflect injuries to vessels, lung, and brachial plexus. 80% are mid-clavicular fractures, which are very common, and they are easy to treat, but also represent a marker of significant energy transfer. And scapular fractures are really, really important. If you remember your days in the anatomy class, and if you get the scapular bone and you try to bend it or break it, it's not easy to do. It's a thin bone, but very resistant. So every time we see a scapular fracture, we know it's a marker of severe injuries, and we try to find another associated injury, which is usually present in 80% of the time. Most of the associated injuries are spinal injuries or intrathoracic organs and abdominal organs. So it's important to realize it's not just rib fractures, but a number of other fractures. Flail chest is the most severe presentation of multiple rib fractures. As you all know, we are going to expand on rib fractures in a little bit. So basically, this injury is manifest either as a pneumothorax, and as everyone knows, pneumothorax could be classified in simple, open, or tension. In blunt trauma, simple pneumothorax usually is associated with rib fractures that lacerate the lung, but can also occur due to deceleration injury or blunt forces that crushes and disrupts the alveoli. And the tension pneumothorax is a clinical diagnosis that needs to be attended to immediately. No X-rays, no CTs, and the focus is respiratory failure accompanied by hemodynamic instability. Now, in a non-tension pneumothorax, like you see in the X-ray here, where this is a pretty large pneumothorax. This is the lung. Everything else that you see here is air. This is a much more subtle pneumothorax, which is a small pneumothorax in the apex, but you see air in the subcutaneous tissue. So these are signs that we need to pay really attention to in the emergency department, particularly in patients that are asymptomatic. We know the chest X-ray is recommended by ATLS, but sensitivity is pretty poor, about 50%. When you see it, is highly specific, 100%, but when you don't, you may miss quite a bit. Whereas the ultrasound is much better in terms of sensitivity and specificity, and obviously the CT chest is the most accurate diagnostic modality. Here are some aspects of the ultrasound. As we all know, the loss of lung sliding, the absence of comet tail or ring down artifact basically confirms the diagnosis. Now, I want to address with you a special type of pneumothorax that we call occult pneumothorax, and the role of tube thoracostomy, because this is being discussed a lot in the literature. You know, these are patients that you don't see pneumothorax on chest X-ray. Eventually, you get a CT for any other reason or an ultrasound, and you identify a pneumothorax. So that's what we call occult, because it's not seen on chest X-ray. Whether or not those occult pneumothorax need to receive tube thoracostomy, and I think that the literature actually is sort of divided. The older papers recommended that you should put a chest tube if you had more than 2 rib fractures, or if the patient would require positive pressure ventilation. The most recent studies recommend that perhaps an occult pneumothorax could be observed regardless of the need of positive pressure ventilation. And if you're going to observe those patients and not put them on the ventilator for any other reason, you need to put them on high flow oxygen to reabsorb the small amount of air that's in the pleural space. So the jury is still out. In our service, we recommend that patients get a chest tube if they are undergoing positive pressure ventilation due to the risk of increasing pneumothorax, particularly during an intervention by neurosurgery or by orthopedic surgeon when the trauma team is not in the operating room. To study this, the WST had a multi-center study that I had the opportunity to participate in 2011. We look at 588 patients with occult pneumothorax. 121 received tube thoracostomy. 448 were observed. Of those that were observed, 27 of them, or 6%, end up requiring tube thoracostomy. So observation is fair when applied appropriately, and a small percentage will require tube thoracostomy, only 6%. 14%, however, failed observation when they were under positive pressure ventilation. So again, positive pressure ventilation really makes a difference, and you need to define in your own service what is going to be your protocol and follow it accordingly, because any variation in your protocol will probably lead to a pneumothorax getting bigger and not being attended by the trauma team immediately. When we did multivariate analysis, we identified the respiratory distress and the progression as predictors of failure. Obviously, 15% that failed develop complications. So you see this is a stepwise process. You observe some 6% get a chest tube. Some will require positive pressure ventilation. 14% will fail observation, and those that fail overall develop more complications. So you need to be aware that these things happen. Interestingly enough, in this large series, no tension pneumothorax or adverse events were observed, and we propose then that observation with careful monitoring may be appropriate. Hemothorax is a little bit different. Obviously, we know how to diagnose it. So the importance of ultrasound and tube thoracostomy cannot be forgotten. The issue of this case that Hayato present to me seems to be a retained hemothorax. This was studied by the WST in a multi-institutional fashion as well in 2012. This was a prospective observation multi-center study of 20 centers, and the inclusion criteria were patients that had received tube thoracostomy within 24 hours from admission to the trauma center and had a retained hemothorax on chest CT afterwards. So we looked at 328 patients. Look, 35% received VATS ×1, 26% received VATS twice, 5.4% received VATS 3 times. And I'm showing this to emphasize the importance of VATS. And even though this condition, retained hemothorax, is not an easy condition to treat, but what we learned from looking at this data is that ideally, you should do VATS between 3 and 5 days from injury. If patients that had retained hemothorax less than 900 cc's, 20% of this patient population underwent thoracotomy for the treatment of retained hemothorax. And these were large retained hemothorax, usually greater than a liter, had either a diaphragmatic injury associated to it, or patients that didn't receive prophylactic antibiotics at the time of tube thoracostomy. And a small percentage, those that have a retained hemothorax less than 300 cc's, were successfully observed. Interestingly, though, 27% develop empyema. That's the natural history of a retained hemothorax, and about 20% develop a pneumonia, which are the two differential diagnoses in the case that Hayato presented to us. So how about this relationship between retained hemothorax and empyema? So we also studied this in a multi-institutional trial at the WST, And when we did multivariate analysis, we appreciated that independent predictors of empyema in patients with retained hemothorax are associated with rib fractures, odds ratio 2.28, injury severity score greater than 25, so severely injured patients, and patients that received an additional intervention. So here you have it. If you have a retained hemothorax, you either go to VATS to remove the hemothorax and clean off all the chest cavity completely early on, between 3 and 5 days, or you're going to put a second chest tube, and then you're going to do this, and then you're going to do that, and then you take the tube, then the patient recurs, you put a third chest tube, and those additional interventions have a 28-fold increase in the risk of empyema formation compared to 2.4 for ISS or 2.28 for rib fractures. So the more you delay your definitive intervention, doing interventions that may or may not work, will lead to a significant number of patients developing empyema. More recently, we looked at the predictors of retained hemothorax in trauma with the EAST in a multi-institutional fashion. And I just want to show to you that we look at 369 patients, 106 of those had the retained hemothorax, and those that had the retained hemothorax were older. And the initial volume on CT is actually very, very important. So you see that patients that have initial small hemothorax have a very low likelihood of developing retained hemothorax, but those that have moderate, which is 300 to 900 cc's, and large, greater than 900 cc's, have a much higher incidence of retained hemothorax compared to those that didn't. Now, I say this because it is becoming standard of care, at least in trauma centers in the United States, that the radiologists, when they read the CT chest, they give you a volumetric assessment of your hemothorax. Obviously, you can look at the images and decide yourself, but you don't know if it's 700 or 900, so they can help you with that assessment. And so here we had all the patients, 369, 106 developed retained hemothorax. Now, here is the size of the hemothorax when they received the initial chest x-ray. So a small hemothorax, only half received the chest tube. Moderate hemothorax, 90% received the chest tube, and large, 90% received. Now, this is the percentage of patients with retained hemothorax after tube thoracostomy. So of this 46% of patients that received a chest tube that had a small hemothorax, 23% still develop a retained hemothorax. So it's, you know, volume is important, but you got to be aware that these things happen and you need to search for them before you send those patients home, particularly if they have risk factors for persistent hemorrhage. Moderate, 44%, and large, about 40%. So volume is important. And here is the overall management in this large series. 33% we did nothing. 30% got a tube thoracostomy, which was successful in 78%. But again, 22% tube thoracostomy alone. So the second chest tube was not successful. So we got to watch that. This is percutaneous drainage, image-guided percutaneous drainage. Just a few received ultrasound or CT. Was successful, again, about 70%, and successful in 30%. Thrombolytics, still some people do this in the United States. It's successful. It's like flipping a coin. 50% will resolve depending on the size of the hemothorax, and 50% won't. This works primarily in the smaller retained hemothorax than larger. This is the Yunker, the suction device strategy to evacuate hemothorax. Nobody used in this series. And here is the VATS data, which is 92% successful and 8% unsuccessful. So it seems, looking at this large data set representing what we do in the United States across large academic trauma centers, VATS has a performance that's much better than all the other modalities. And if you look at the predictors of recurrent or retained hemothorax, you have them all here. But the most important information is this: early intervention leads to an empyema rate, which is cited in the literature between 15, 16 to 30%, less than 1%. So here again, my plea that if you're gonna deal with these patients, use VATS early, because the incidence of empyema is gonna be much, much less than if you put a chest tube or if you use thrombolytics and another chest tube and if you delay VATS. Briefly talk about pulmonary contusion, because the underlying lung injury to rib fractures is pulmonary contusion, carries a mortality of 28%, often is missed early, and obviously the pathophysiology is related to this big hematoma in the lung parenchyma leading to poor gas exchange. Usually it's caused by rapid deceleration or multiple rib fractures. The radiologic findings may take 4 to 24 hours to develop. So even in patients that have significant chest injury, you don't see a pulmonary contusion on the initial chest x-ray, doesn't mean it's not there. That hematoma is forming. And if you follow them up with imaging, you're gonna see images that blossom between 4, 6, and 24 hours. And obviously CT is a lot more sensitive. So for those that do CT, for everyone, immediately you're gonna make a lot more diagnoses of pulmonary contusion than those that use x-rays. There are a number of strategies to deal with pulmonary contusion. I will mention to you that being careful about fluid resuscitation is very, very important, because the hematoma in the lung leaks out and patients have much worse compromise of their oxygenation and ventilation if you flood the injured lung with saline. Obviously, chest PT, oxygen, pain control, epidural was mentioned in the discussion, intercostal blocks, and eventually internal fixation of ribs when appropriate and possible are all part of the current standard of care for pulmonary contusion. Other things like nitric oxide, surfactant, and the forever discussion between non-invasive and invasive ventilation is also applies to pulmonary contusion. Here is some data whether or not CPAP should be used, and you find everything in the literature, anti-CPAP or pro-CPAP. I think the jury is out there, but if you can avoid intubating these patients early on and maintain their oxygenation with CPAP, they are better off. Flail chest, everyone knows what this is. Here, the focus is to treat the patient's respiratory problem and not the x-ray or the paradoxical respiratory movement. You look at the chest and you see the chest caving in and the patient takes a deep breath and everybody freaks out. That's not the problem. The problem is the underlying pulmonary contusion. Operative stabilization is rarely necessary, but it's very effective when used appropriately. So consider, particularly for multiple displaced ribs, operative intervention to stabilize the chest wall. This is the burden of flail chest, and the burden is very, very high. So you have a patient with flail chest, patient is splints, has poor pulmonary toilet, decreased respiratory function, ends up on the ventilator, then develops the barotrauma with a ventilator-induced pneumothorax, increase the risk of pneumonia. For every day the patient stays on the ventilator, end up with sepsis, stays for a prolonged time in the ICU, and eventually dies. So this is not uncommon to see, particularly in the elderly population, and that's why we need to get it right at the beginning when the patient comes to the hospital, watching their resuscitation, providing adequate pain control, chest physical therapy, and non-invasive mechanical ventilation if possible. Here is the data from the NTDB, looking at 3,464 patients with flail chest and the resource utilization. At this time when this paper was published, 60% end up on the ventilator, 82% end up in the ICU, 44% got a chest tube, so on and so forth. So you see that the importance of these injuries in terms of resource utilization. And more importantly, 16% of patients with flail chest died in this large data set. These are some recommendations from Anesthesia Critical Care and Pain Medicine journal, particularly from Europe. These are 5 studies and 1 meta-analysis are included in this publication, and they favor non-invasive ventilation for patients that have hypoxia. They describe a decreased need for intubation, a decreased incidence of pneumonia. They reduce hospital stay, so resource utilization by 4 days, and reduce mortality. So we need to get used to non-invasive ventilation, aggressive use of non-invasive ventilation in those patients. Mechanical ventilation has its indications, obviously, and if you need to use mechanical ventilation, use low tidal volume ventilation with a plateau pressure about 30 centimeters of water, as we do for ARDS. Pain control, they also emphasize it's very important. They recommend for patients with intense pain, morphine titration. They use either they use the NRS or a verbal rating scale for pain control, but they emphasize the importance of avoiding opiates and using multimodal analgesia pending no contraindications. Because multimodal analgesia seems to be more effective. This is in accordance with the EAST guidelines for pain control. They mention epidural analgesia versus opioids, and they also mention multimodal analgesia versus opioids, favoring those 2 modalities to avoid the opioid crisis that we live in North America. And in terms of mechanical ventilation, they talk about the patients that should not be on a ventilator with using that old concept that we can stabilize the chest wall by putting them on positive pressure ventilation. That's an old concept that should be abandoned, because the ventilator is not supposed to stabilize the chest wall. The ventilator is supposed to provide better oxygenation and ventilation for patients with pulmonary contusion and flail chest, which can be obtained with a trial of non-invasive ventilation first. So abandon the use of ventilators for chest wall stabilization. Obviously, aggressive chest physiotherapy and eventually an epidural, like was commented by the panelists, is important. I learned something from Dr. Ingo Marzi visiting his trauma center recently. They love this rotational therapy for all patients in the ICU. And they tell me that patients with thoracic injury in Germany undergo this rotational therapy, the bed that moves from side to side, and they have better outcomes. And they've published this in Current Opinions of Critical Care. I think this is a good strategy. My experience is that patients go crazy when they rotate from side to side. They get dizzy, they throw up because it changes their equilibrium and their stability, but it seems that the clinical outcomes are adequate, as Dr. Marzi and his group has shown in this paper. We have used prone ventilation for ARDS for a long time, and there are many studies suggesting that prone ventilation is important. The problem is that there are several complications and disadvantages associated with prone ventilation, particularly in the fresh acute trauma patient that has just been intubated, inadvertent extubation, issues with intracranial pressure, pressure sores, facial edema, tongue edema are seen frequently. Obviously, it's hard to do in patients that you have an open abdomen, and nobody knows exactly how long you should keep the patient prone and how often you should go back to the supine position. So there are some issues to deal with, but this is what we used to prone patients about 25 years ago. When I arrived in San Diego, we had this device. We tied the patient to this device, and we used this device to move the patient in block. But you can see in the ICU, we need 6 to 8 people to prone somebody. About 20 years ago, the company KCI approached Dr. Hoyt, who was my boss at the time, and myself in the ICU, and said, hey, we have this prototype of a proning bed that we would like to test. So our unit in San Diego was the first unit, at least in the United States, to test their prototype. So they brought in this monster to the ICU. But this was nice because with the push of a button, the patient would be turned belly down and would stay in this position. You see, this is a prototype. It's not ideal, but the development of this prototype helped a lot of people and led to this bed that you all know are available worldwide by KCI, which is the rotoprone bed, which was tested in our unit. So now you have this resource, which is a very nice a bed with many different positions that you can take. You can do side to side, you can prone, you can elevate the feet, you can elevate the head, you can do all sorts of things. And when you put people on prone ventilation, this is the what you see, an initial pulmonary contusion that then gets worse, more localized, and then eventually patients start getting better over time. And in about a week's time, you see that the x-rays are almost back to normal or as good as it gets. So prone ventilation is important. We've used prone ventilation with inhaled nitric oxide for ARDS. And sometimes when you have massive pulmonary contusions, nitric oxide also helps improving PO2 FiO2 ratios and VQ mismatch. This is data from, again, the NTDB on flail chest injuries. And for patients that had significant pulmonary contusion, they stay about 7 days on mechanical ventilation, 9 days or 10 days in the ICU, and 17 days in the hospital. So again, these are serious injuries, and the underlying pulmonary contusion is probably responsible for most of this resource utilization. I just want to use my last 2 minutes to finish with damage control thoracic, pulmonary injuries, hilum, and I'm not going to talk about resuscitative thoracotomy in the interest of time today. So just remember that staple tracheotomy is a useful strategy, particularly in penetrating trauma, which we are not talking about today, but I just want to show to the young people in the audience that if you have 2 holes in the lung, you just stick a TIA stapler in the wounds and staple across, and then you ligate eventually air leak areas and eventual bleeding. You can do that with clamps as well if you don't have the staplers, and the procedure is about the same. For lacerations in the lung that could happen in blunt or penetrating injury, there are peripheral. You can do stapled wedge resections and control bleeding and control the air leak that way. And this is a very effective procedure that we should use more often. And for pulmonary hilum, this is an infrequent problem, but it's highly lethal. So you need to be prepared to control the hilum, particularly in penetrating injuries, and be prepared to do lung resection. Here you need to decide if you do partial or complete lobectomy versus pneumonectomy. The problem is that 15% of ED thoracotomies require hilar clamping, and intraoperative deaths occur more often due to the inability to ventilate, uncontrolled bleeding, and air embolism. So these are the 3 issues that kill those patients that need hilum control in the operating room. So people present with major air leaks, which is a rare presentation. Usually they present in shock because of the associated vascular injuries and major bleeding, massive hemothorax, high chest tube output. And obviously, when you decided based on high chest tube output to open their chest, you see intraoperative identification of pulmonary hilar injuries. This is a very old data from Dr. Wilson, but still very relevant. He looked at 7-year period, 25 patients with hilar injuries, 15% of their 161 emergency thoracotomies, 18 patients, they were able to clamp the hilum, and 10 survived. Remarkable survival in those that they were able to clamp the hilum. On the other hand, those that didn't receive a clamp across the hilum and the surgeon decided to attempt direct bleeding control, only 1 survived. So again, if you see an injury in the hilum, you got to put a clamp across the hilum, and then take your time to decide what's the best next step. 6 patients required lung resection of a lobe or a segment, and 5 of them survived. So again, if you need to resect some lung, but first put a clamp in the hilum. Obviously, those that didn't died of blood loss, and the 6 early deaths were probably supposed to be due to air embolism. So again, the early vascular hilar control is mandatory, and it's a life-saving maneuver. Why? Because you avoid drowning the other lung, the non-injured lung. So the injured lung bleeds into the non-injured lung, and then you have both lungs compromised for ventilation and oxygenation. Obviously, you do it to control hemorrhage and to prevent air embolism. And this is the procedure, right? So we need to train, we need to be facile in selective intubation and control of the hilum with a vascular clamp. And once you do that, the patient survives, then you're gonna see what you're gonna do next. If you're gonna resect some lung, repair some vascular injuries or whatnot, call your thoracic colleague, but being able to perform this life-saving maneuver is very important for all trauma surgeons. So again, hilar clamping, then bleeding control is your second step. Consider lung resection, temporary closure of the chest cavity. It's fair for damage control. And you need to think about alternatives to conventional techniques. And this is one of them that described by Dr. Wilson in 2003, what's called the twist technique. You open the chest, you transect the inferior pulmonary ligament, and basically twist the hilum, twist the whole lung. So this is the head of the patient, and this is the foot. So with your left hand underneath the lung and your right hand above the lung, you twist this on a clockwise fashion. And this is what you obtain basically with the twist. And eventually you put a number of laparotomy pads around the twisted lung to maintain the lung in that position, temporary closure of the chest, and then go to the ICU with one lung ventilation only. And then you come back if the patient survives and is more stable for definitive repair with your thoracic colleagues. I'm going to stop right here. I'll thank you again for your attention and for my giving me the opportunity to participate today.
Thank you very much, Raul, for a great tour de force. We've had a very interesting question from Chris Pape, and I'd like him to ask that in person. Chris.
Okay, this was completely unplanned. So first of all, congratulations, because this was a really fantastic talk. You pretty much covered everything. And we have in our discussions have always been puzzled about what are the best indications for surgical fixation of rib fractures. And so I was wondering if you have an answer to that. I put down some of the ideas into the chat. So is it biomechanical instability? Is it the patient is not able to inhale enough or something, like when you try to wean him? Do you go by the X-ray? Do you go by Horowitz ratio, or what are your recommendations?
Yeah, that's a very, very good question, Chris. Thanks so much. Very good question that I hoped before this I wouldn't have to answer. There is so much controversy about this, right? So I divided patients into 2 groups for rib fixation. To me, matters if the patient is on the ventilator or if the patient is not on the ventilator. So for those patients that have multiple rib fractures, flail chest, displaced rib fractures with significant pulmonary contusion that made some progress on mechanical ventilation, so that they are giving you some indication that they are gonna make it. I think that fixing the ribs prior to ventilation weaning will allow you to wean them faster and will improve their respiratory mechanics after they are weaned from the ventilator. So that's one type of patient that I really care about because I see tremendous benefits in those patients. Now, for patients that are not intubated, that are struggling to breathe, that you are treating them with non-invasive ventilation, and they have perhaps significant pain problems, which may cause their respiratory distress, and have multiple displaced rib fractures. Those are the patients that if I try multimodal therapy, if I try epidural analgesia, and they're not making progress, I take them to the operating room to fix. Now, having said that, if you look at that population as 100%, about 85% will respond to epidural or multimodal therapy and will not require, in my opinion, rib fixation. So it's still an important procedure for the immense minority.
Raul, thank you very much for your talk. I've got a few questions. One is the timing of VATS. As you very well know, Joe DeBose was the leading author on the ESTES study. He didn't see the timing of the VATS to predict outcome. Nevertheless, the E study did. Was that an issue of the size of the cohort?
No, I think I think that the differences in those two studies are really the change in practice that happened between the DuBose study and the EAST study. 8 years went by. I think we got smarter. We learned this. We start adopting more non-invasive surgery, and thoracoscopy and VATS was one of those techniques. And there were small studies between those 8 years that suggested that early VATS was positive. So I think what you're seeing is just the natural trend of the country changing and using VATS more often early on.
Right. And the second question is, you're still advocating the lung twist. I don't use it, and I even discourage, if I have a clamp, there is no need for the twist. Why are you still doing it?
No, I was just showing to be complete as options and techniques. I have used lung twists twice. Once it worked momentarily, and the other time it didn't. But it is a technique described, and so I want to show it for sake of completeness. But obviously, the image with the clamp across the hilum is what matters. And to that end, we've taken people out of the operating room table in a damage control situation with the clamp in place. Right. You know, and that's fair too. Go to the ICU, if the patient survive, you come back at a better day.
That's the same thing what I heard from Colombia. If you can't take the clamp off and the patient is, you don't want to take the lung off, because you know the mortality is 70 or 60% at minimum. So you keep the lung and you can still release the lung and
That's
sometimes perfuse again.
That's right. And now I'm going to make a comment about pneumonectomies, because there are a couple recent studies suggesting that if you are forced to do a total pneumonectomy in those circumstances, the mortality rate may be decreased if you put those patients on ECMO immediately after. So ECMO now is being used not only for patients with significant pulmonary contusions, but also for patients immediately post pneumonectomy.
Right. But I think for the audience, we need to say as well, the least lung you take, the better is the outcome. If you go further, it is a stepwise increasing mortality, whether you take a wedge versus a lobe versus a lung, there will be stepwise increase.
Right, correct.
Can I make you a few questions also? We know that most of the patients that we see in the emergency department are not with severe thoracic trauma. They have mild or moderate thoracic trauma, and some of them can be discharged from the emergency department. there have been a lot of criteria and a lot of controversy. Which are the criteria for discharging these patients home, and if it's safe to do it? What do you think about it?
It depends what injuries they have. If you have somebody with one rib fracture that's asymptomatic, healthy, young, reliable, that will come to the hospital following instructions if they develop symptoms, has no pneumothorax, yeah, why not? But for patients that have an identifiable injury on imaging, I think those patients, because of the risk of progression, deserve at least a period of observation in the emergency department or in the hospital.
The second question is about damage control thoracotomy. You talked about leaving the thorax open, and in the literature there are a lot of methods to keep the thorax open, to make a temporary closure like we do in the abdomen. What are your thoughts about this?
So the way I do it, I pack the chest with laparotomy pads and put a adherent plastic drape on it. We call here IOBAN. I don't know what's it called in Europe, probably IOBAN as well. So I covered the chest with an IOBAN and put a couple chest tubes in the posterior aspect of the thoracic cavity and one angle chest tube on top of the diaphragm and go to the ICU. It's easy to remove, and you get direct access to the chest if you have to for any reason.
Okay, thank you for the fantastic presentation. I give the word to other.
Raul, there was a very interesting question from Shaheen Mosheni. Hello, Shaheen. Regarding the size of the intercostal drain, since there is a lot of talk, especially from the group of Arizona, that are publishing good result on smaller chest tube like pigtail drains. What's your opinion of you and Peep, of all the panelists about that?
Yeah, so this is again a controversial topic. I don't believe in the small drains. I believe in the good sized drains for hemothorax, because if clot forms, then no drain is going to work, but it's more likely that a smaller drain will fail more often than a larger drain. So I use larger drains. So for pneumothorax, I use a 28 French chest tube, smaller tube for adults, and I use a 32 or 36 French tube for hemothorax. And obviously we treat them all under suction. So your question is important because it's controversial, and as it relates to your case, you know, the second time you put a chest tube and you said, well, there is this serohematic fluid coming out for 10-15 days. You know what that is? That is a non-evacuated retained hemothorax that causes pleural irritation, and you have this serous sanguineous fluid coming out, but the hemothorax, the retained hemothorax, the clot's still there, and that's what gets infected. And so imagine if that would come out through a small pigtail catheter. It doesn't. So pigtail catheters may be good for very small hemothoraces, 300 cc's or less, immediately in the ER. That's what the Arizona guys are doing, and under suction. But I still have not embraced that.
Thank you very much.
Okay, I think 72% of the attendees wanted to use it. Dr. Coimbra says we should use it very early on. It sounds like a very good time to move on to our next presentation from Pietro Bisagni on the use of VATS in COVID. So Pietro, over to you.
Yeah, thank you. Thank you very much for ESTES to giving me the opportunity to share our experience that we had during this really front line on the pandemic. Well, we go back to February 20, when we in Codogno diagnosed the first Western patient affected by COVID-19 bilateral pneumonia. So in the next weeks, our hospital in Lodi and Codogno have been overwhelmed by a really large amount of patients with respiratory failure and need for oxygen. Well, around 15% of the presented needed non-invasive ventilation, and around 1 to 2% of the presented need tube placement, ventilation, and ICU stay. So these large amounts of patients was really important for us, and both interstitial pneumonia and oxygen and ventilation both lead to often to super infection of these patients. So they had parapneumonic pleural effusion going to empyema. On the other hand, pulmonary stiffness, and of course the need of positive end respiratory pressure, as described by many authors, to treat this patient acute respiratory failure, lead to a major barotrauma that sometimes lead to pneumothorax or pneumomediastinum. The incidence of pleural effusion was about 2 to 6% according to the literature, and the numbers of complication of barotrauma was about 2 up to 15% of the patients. The first treatment of both these complications was, of course, intercostal tube placement or US or CT scan guided drainage, as discussed before. But the efficacy of those treatments was not always present. And well, me and our surgical team was then involved in the critical choice of surgically treat some selected patient not improving after treatment with drainage, but considered fit for an attempt of minimally invasive surgery. So I here present 2 representative cases. The first is a 57-year-old male with a history of smoking and a Wegener granulomatosis that was admitted for COVID on April 2020 for COVID pneumonia. He needed CPAP from the start in order to improve his respiratory function. He was treated well. It was last April, so hydroxychloroquine was again used, and tocilizumab we participated in a study about 8, and other antiviral drugs. But after 10 days treatment, he suddenly developed dyspnea, chest pain, and severe hypoxemia, and that was a X-ray. This patient was treated, of course, with a tube thoracostomy, but the CT scan showed again a large pneumothorax, and his respiratory condition went worse and worse. So we together decided to try to have the first thoracoscopy in this patient, where we did the thoracoscopy with 3-port thoracoscopy, right thoracoscopy, with the patient placed on his flank, of course. We found hydropneumothorax, and at the apex, as you can see here, we found a large blebs, which was losing hair. So with a single cartridge, as we do in simple pneumothorax due to blebs, we just resected it, and that was it. Then we take some samples in order to have cultural exams, and we put drain, and we did a pleuric we completed the procedure with a partial pleurectomy. Here is the CT after 12 days after, and you see a partial resolution of the pneumonia, of course, not a complete resolution, but a complete expansion of the lung, and at the apex you can see the staple lines. The other case is a male, a younger male, 49 years old, with just a history of arterial hypertension, admitted for COVID pneumonia with severe hypoxemia. He suddenly needs oxygen supply, then CPAP, but after 3 days, he needed orotracheal intubation and mechanical ventilation. He was treated again with hydroxychloroquine and antiviral drugs, but a CT scan he showed an empyema with hair level here at the basis of the right lung, and he didn't have the ability to be ventilated anymore because of the large amount of interstitial pneumonia, again also in the other thorax. So we put him on the surgical theater, and we perform again a thoracoscopy. The first treatment was again tried to be attempted by US guided drainage, but this wasn't able to solve the situation. So we performed this thoracoscopy, and again we found many different, a lot of fibrin and many different collection of fluid. The gentle and really careful attempt to remove the fibrin was performed by those instruments here, and we went on until we finally could find the place of the abscess. Then we collect some fluid and again some fibrin in order to do the exams with the laboratory. And after a lot of drainage and washing, we completed the release of the right lung, and then we complete the intervention with the 2 big drainage. There was both 28 and to solve the situation. That was a CT scan performed 20 days later when the patient was ready to leave the ICU unit, and the expansion was complete, and of course the empyema was quite completely solved. We had other 3 cases during the first wave of the pandemic that are here represented, and in the last period we had some other cases, but the number of complications fortunately diminished, probably due to our ability to treat better those patients. So just some take-home messages. Secondary spontaneous pneumothorax and parapneumonic pleural effusion are common complications of COVID-19 infection. Video-assisted thoracoscopy is a safe option for persistent pneumothorax after chest tube positioning of pleural effusion of high grade for patients that are tolerant for surgery under general anesthesia. VATS allow to manage COVID-19 complication and improve respiratory function and reduce the need of oxygen and of course of ICU stay. Of course, be careful about aerosol contamination during this procedure. Thank you so much for ESTES for giving me the opportunity to share this data.
Thank you very much, Pietro. Panel, do we have comments? Peep, what do you think?
I was asking Pietro if those cases were related to the first hit of COVID during the COVID outbreak. Or what about during the second wave that we've been experiencing over here in Italy?
Yes, we have some cases, but it was less than before, of course, Hayato. Hopefully, because we are more able to treat this patient, let's think it. On the other hand, could be different ability to ventilate this patient could be an answer about it.
Pietro, and nice talk. I think it was a very elegant two cases. What was your drain management prior to going to the VATS?
Well,
particularly the last case with a massive new empyema. Did you try a drain first? Which drain?
yes, it was a 24 drain placed under US guided, but it was not complete able to solve the situation. So after 2 days, the problem was the management of this patient, and we decided to go to OR.
And how did you manage the drain after the VATS?
Well, in case of pneumothorax, just leaving it until we have loss of air, and then doing an X-ray or in some case CT scan and remove it. And in case of empyema, we removed first the anterior one usually, and then we left the posterior one until it drains. Then I want to have an imaging ultrasound if we are able to have good ultrasound imaging. Otherwise, CT scan before to remove the drainage, just to be sure not to left possible anything inside the thorax.
And Pietro, the timing of the VATS in those patients, now they have usually bilateral pneumonia. So they are poorly ventilated, poorly oxygenated. And now you're gonna put one lung down. Did you feel that as a risky avenue?
Yes, we, particularly in the second case I presented, we had to stop many times during the procedure in order to ventilate the other lung, because the oxygenation wasn't enough. So that's a big problem. Anyway, we didn't see any different way to do it. We performed part of the intervention with ventilated lung, and that posed my, of course, our actions more difficult, but it was necessary.
I've got a question actually for Professor Coimbra. But first of all, can I start off by saying two absolutely fantastic talks? Really enjoyed them. I've learned a lot this evening. This evening it is in the UK, but no, I really appreciate that. Professor Coimbra, you were about to discuss, but ran out of time, the role of resuscitative thoracotomy in blunt chest trauma. Hugely controversial, and we normally find that people are in two camps, proponents or opponents, but very vehemently in either camp, mainly based on the sort of really poor outcomes from basically thoracotomy and blunt chest trauma. Where do you lie in this debate?
So in blunt trauma, more and more, I'm avoiding as much as I can resuscitative thoracotomy if the patient has arrested prior to arrival, has undergone CPR for more than 15 minutes and has no airway. I think we own the patients a reasonable chance of getting his day in court and being treated if they arrest in front of us upon admission to the trauma center. We published a paper a couple months ago in Critical Care comparing open versus closed CPR for blunt trauma patients. And there is no question that patients that arrest at the arrival of the trauma center benefit from open CPR, and everybody that gets closed CPR just dies. So provided that the period of CPR is short and you have a definitive airway prior to transport or prior to arrival, we give them a chance. Otherwise, more than 15 minutes, no airway, we just stop. Obviously, put an ultrasound in the heart. There is no meaningful rhythm. We just don't do anything.
Yeah, brilliant. Thank you.
Okay, a couple of very, very good presentations there. I think that we have had a really good start to 2021 as far as the webinars are concerned. If only it had been such a good start everywhere else in the world, it would be wonderful. This, I think, is a very good time to take the opportunity to thank our presenters, Raul Coimbra and Pietro Bisagni, and Hayato Kurihara for his great case presentation. I'd also like to take the opportunity to thank Jorge Pereira, Peep Talving, and Nikhil Misra for their great panel contributions. I hope that you've enjoyed this webinar and will be able to join us in 2 weeks' time for our next ESTES webinar on the closure of complex soft tissue wounds in emergency surgery, looking both at the difficult abdominal closure, the laparostomy, and also difficult extremities. 2 weeks after that, we will be looking at the difficulties of trauma care, not only in the times of COVID, but also when resources are limited. And I hope you'll be able to join us for those. We have a great backstage team, and I'd like to take the opportunity to thank Alan Biloslavo, Diego Mariani, and Mauro Zago for their input as well into this evening's show, performance, webinar, whatever. And as I say, I hope you'll all join us again. Thank you very much for joining us now. And thanks again to the panel and to the speakers. Thank you.
Thank you.
Bye, everyone.
Thank you so much.